Thank you very much, Srini, and I'll tell you that some of the things I will show you I've done myself, but most of them come from other people. And a lot can happen during iliac interventions, from rupture and perforation, dissection, acute thrombosis and embolization, subintimal stent placement without a proper reentry, plaque shift, jailing of the contralateral CIA. And then I've never seen this, but obviously AV fistula can also occur. So I think the most important and threatening thing that can happen during a procedure is a rupture or perforation of the artery. And I think the most important thing to do is to keep calm and then start with a balloon tamponade. Take the time to obtain a contralateral access and then use this contralateral access or a more distal access that you obtain, for example, in the SFA, on the ipsilateral side for covered stent placement and or balloon tamponade. And then typically you can get away with it. Here an example of the balloon tamponade. You can see clearly the rupture, and you can also see the extent of the hematoma with the bladder completely displaced towards the left side of the body. And this buys you some time in order to get everything ready for the final treatment or to call the vascular surgeon. Another example, treated with covered stents. That's not really very difficult, and this is actually a complication from an abscess drainage coming in from another hospital. You can see the drain in situ, and this patient was also treated with a covered stent. Dissection is something we see sometimes after PTCA. You can see the imaging with a contralateral injection. What I prefer to do in those cases, of course, we typically have a CT angiography for planning purposes and to see the extent of the dissection. But I think it's very important not to treat initially from the same side, because you will probably run into the same location again. There's a tendency to go and stay subintimal. That's why I prefer to use a crossover procedure. Then confirm your intraluminal position and then snare the wire and get everything done. Then you proceed with the stenting of the dissected artery from the ipsilateral side. You can see here the original dissection path, and this is the guide wire following the intraluminal path, which is completely different. And then with a self-expanding bare metal stent, you can obtain a result as you see on the right-hand side. Then this is a case of an embolization. A patient was convinced that the occlusion of the left external iliac artery was caused by a CT angiography that was performed for another reason. We had documented at that point the patency of an external iliac artery on this September 3, some years ago. There was an acute occlusion of the external iliac artery, and the day before the occlusion, he had a CT scan that still showed patent external iliac artery. The patient had claudication but was still manageable, and we sent him away on oral anticoagulant therapy for 10 weeks, and then he came back for the recanalization. And this is what happened after the predilation of the external iliac artery after crossing. Huge embolization into the internal iliac artery that then of course needs to be treated. In this case I stayed ipsilateral 6 French sheath with a Y connector, and then using vacuum assisted thromboaspiration I was able to get all this material out, restore patency in the hypergastric artery, and then proceed with stenting. And not surprisingly, the control angiogram distally, although this all looked perfect, showed a subocclusion of the profunda and also distal embolization into the TP trunk. And this was then treated again with vacuum assisted thromboaspiration in a crossover fashion with a complete restoration of the flow. Then this case, subintimal stent placement without re-entry that was done in an emergency setting by a local vascular surgeon. This is the CT angiography prior to the procedure, and you can see that there is some aneurysmal disease of the aorta with an occlusion on the right-hand side of the external iliac artery. This was after a coronary bypass procedure with a large bore access um, during the surgical procedure for the perfusion. And then here you can see in more detail the left-hand side with some stenosis of the left common iliac artery, and also an occlusion on the left-hand side that was not touched, that was already occluded. These are the images from the initial procedure where you can see that access was obtained, crossing was performed, and you can see actually a pretty good looking picture, but look at the aspect of the distal aorta and also of the common iliac artery that seems to be occluded, while it was not occluded on the CT angiography. So what happened here was a complete subintimal stent placement without a proper re-entry in the aorta, and the patient therefore continued to have acute ischemia of the right leg. And this is then the procedure that was done to restore flow again, suboptimal flow with the injection from the ipsilateral side. You can see that the guide wire follows a course outside of the stent initially, was able also to get inside the stent again, but then you can see that there was no flow upon injection of contrast into the stent, indicating really the subintimal position of the stent and also exclusion of the flow from above. So in that case, I punctured also contralaterally, was lucky enough to get into the lumen in the external iliac artery, and then also was able to perform a crossover. And in this case, a rendezvous with snaring was performed in crossover, and then relatively easy it was to pre-dilate the right-hand side, and then with some additional self-expandable stents, I was able to restore flow, and at least the acute limb ischemia was resolved at that point. Then always be aware of plaque shift, although typically in a unilateral disease, I don't do a kissing balloon or kissing stent technique. I typically try to stay on one side. And that is also what I teach my residents and fellows. And following this algorithm, one of my colleagues performed this procedure, but you can see that the occlusion in the right common iliac artery was actually not crossed intraluminally, but probably subintimally, and also on the outer side of the artery and not on the medial side. And this is really a situation where you need to use a stent or a balloon on the other side in order to avoid the plaque shift that occurred in this case. This was patent before, and you can see now after stenting that there is an occlusion or a stenosis in the proximal part, which was also demonstrated on a CT scan that was performed some weeks after. Patient developed claudication on the left-hand side. It was not present before, and then this was a relatively simple fix to put in a second stent also on the left-hand side. Then one of the other issues that occurred in the past, especially with self-expandable stents, because they were really prone to jumping forward, and that could lead to jailing of the contralateral common iliac artery. That can be very difficult to treat. In this case, the patient also had or developed a stenosis of the right common iliac artery that at this point was only balloon dilated, because I always went through the interstices of the stent with my guide wire, was not able to pass beside this, and you can imagine why that was. But the PTA actually did a good job, and patient symptoms resolved completely. So in conclusion, complications do occur and may be life-threatening. Be prepared with your endovascular and surgical backup, and I think most importantly, especially with the ruptures, keep calm. Thank you very much for your attention.